You might have a little thing, I'll have a little thing on your screen that says, do you know this is being recorded?
Yeah, and then we click, got it.
Yep.
Morning, Arthur.
Good morning.
Hi, Debbie and Herb.
I imagine Maureen will pop in. See if I can figure out who I know really wanted to be here and might be missing it. Let's see. Oh, Ed Frankenberry did not get it. Okay. Let's see. All right. One, two, three, 4, 5, 6, 7, 8. All right, Douglas, I know Ed Frankenberry is going to log in a minute, but if you want to get started, I think that's fine.
Okay, so good morning, everybody. I guess we're a relatively small but high quality group here. And as we've discussed in the past, what we try to do is provide evidence-based information gleaned from the best sources we can find, particularly from NIH and CDC and some of the leaders for the New England Journal of Medicine and other sources as we can. And the other committee members for the Health and Wellness Committee for Newton at Home are Dr. Arthur Glasgow and Dr. Cynthia Hill, who's not with us this morning, but we'll get the recording later, and Dr. Herb Plavnik, who's with us. So I thought I'd start out with the good and important news early on here, and then open it up for a little discussion as to how we process this. Particularly, I'm been reflecting on a webinar that was hosted by the Annals of Internal Medicine with the director of vaccine development at NIH, Dr. Mascola, and Cynthia Cotton, who is a member of the CDC's Advisory Committee on Immunization Practices that were responsible for putting together the latest recommendations on booster doses. And I know that's the topic that everybody is interested in. And Dr. Mascola particularly, put together the immunity of vaccines and COVID-19 and what the booster doses mean for us. And incidentally, this was listened to by about 2,000 internists around the world, and they submitted questions beforehand, about 700. So they had a lot to go on. But the bottom line is, particularly for me, and good morning, Ed, I'm glad you could get on. The bottom line for me on the issue of boosters, for particularly, we're talking about the Pfizer that's been approved for those 65 and older, is that it, particularly for the Pfizer mRNA, it really is a 3-dose regimen. And the way the immune system works, Dr. Mascola described that the first 2 were really kind of priming the immune system, and that the 3rd dose given 6 months later is really the one that establishes more durable protection, which probably is the reason that Rochelle Walensky, head of CDC, made this comment that once we have the booster, that's it, meaning that we are pretty good to go for a good while, all things considered. And he explained that that this is actually the dose regimen for other vaccines like hepatitis B. The 2nd dose is given about a month after the first one, like Moderna and Pfizer. And then 6 months later, you receive the 3rd dose, which completes the series. And that's particularly important. And the immune system likes to rest in between. And so what is it doing while it's resting? Well, the B cells that have been primed for making antibodies against that spike protein and particular parts of it continue to mutate and mature and broaden out their response with potential antibodies for the next round, if it should be confronted with the pathogen again. So that then when it gets this booster dose at 6 months, that really sets one up for being well protected and more durably protected going forward. What are the clinical implications of that for us as individuals and for the epidemic broadly? Well, it would appear that this is going to give us, those of us who've had the booster for Pfizer and soon probably for Moderna and Johnson & Johnson, good protection for a good long while. So good morning, Myra. Let me just repeat that last point. With the booster dose for those who are not immunocompromised, but who are just receiving it because you're 65 and older or qualify for other reasons, that the immune system is really then well established going forward. They expect that COVID will be with us for the foreseeable future, and there may well be additional booster doses in another year, something like we received for influenza, and maybe there would be a different configuration. The next year may let us know. Possibly this could change in 6 months, but as best these folks see, we should be well protected going forward. And part of the evidence that they reviewed on this was from Israel, where they have immunized millions of people with the booster dose, first for everybody over 60 years, and now since I believe August, they've broadened it out to everyone in the population who's received Pfizer, and Pfizer has been the primary vaccine there. And they've reported on 1 million over 1 million people who had the booster dose compared with those who had just had the first two. And they noticed that the rate of infections was reduced by about 10-fold within a couple of weeks. And the proportion of people who became severely ill was reduced by 20-fold with the booster dose after about 12, 14 days. So that is pretty solid evidence. Such as it is, one can quibble with whether it's, there might be biases in the way the data was collected and things like that. But basically, it confirms the basic understanding of the immune system that the booster dose really makes a big difference, not just a subtle one for bumping up. So does that allow us to notch down our fear factor with COVID, considering it what our own experience individually might be is something more akin to getting a bad cold, or certainly a very, very rare potential for getting severely ill, at least for the foreseeable future being perhaps 6 months or maybe up to a year, and I'm sure we'll be hearing more about that. If we have a bad flu season this winter, that would probably be a bigger risk to our health and lives. So that's informed personal decision making for Sally Craig and myself as we consider heading to places like North Carolina, where we were, and Arizona, where we will be later this month, where there's quite a lot of COVID and not everybody is vaccinated. So I would just like to stop there and see how this sits with you, and whether what your comments and thoughts are about level of concern, and whether it changes your thinking or might change your thinking in terms of your own personal actions.
So Douglas and
and
I will watch the screen to see, but feel free to unmute yourself if you have questions. And if you don't seem to be able to get a question in, raise your hand and we'll watch for you. I see Barbara over there.
Barbara?
Yeah.
Uh-huh.
Hi, yes. I am wondering, having received the Moderna vaccine, what's going on? We haven't heard very much talk at all, and it seems like it's lagging behind the Pfizer development. Can you tell us what's going on with Moderna?
Yes. In the next few days, the FDA is going to be reviewing the application from Moderna, and then another day or so afterwards, I think it's actually later this week, for their application for booster doses. Okay. So, and I fully expect that will go through. And then a few days later, they'll be reviewing the application from Pfizer for immunizing children, 5 to 12. So all those things are going to be coming hot on the heels of our discussion this morning. So there'll be a lot of news coming soon. And I think we can expect that they will probably approve it.
Yeah, thank you.
Alan?
Is the booster dose a different strength than the first two doses?
Good question. For Pfizer, it's the same. It's just a third inoculation of the same formulation, the same volume. The Moderna, as I understand the application that I saw someplace, it's going to be half the current regimen. And I think the reasoning for that, and now I'm speculating, this is not evidence-based from someone else, is that Moderna has shown that it's a bit more durable. With the first two doses, you get stronger, broader protection, it seems. And the side effects are a little bit stronger with Moderna. So there may not be as much need to have the maximum full strength dose. And as you may recall from the newspapers, the dose of mRNA even though it was a slightly different formulation, was also about double what was in the Pfizer, which may have accounted for its durability and perhaps also for the side effects that are sometimes a little stronger. Does that help? Mhm.
So specifically for Moderna, you have to make sure that you're getting the booster or half dose.
Yes,
Whereas
when
you
it's
weren't really concerned when scheduling for a Pfizer third shot.
right. That'll be well known to the person putting the needle in your arm. Currently, for those who have gotten the booster dose for Moderna because they were immunocompromised, that is the full dose. And that was appropriate because you really need an extra lift for those who are immune compromised. But for those over 65, which will be the first large group, probably if they follow the system with Pfizer, that it will be for everybody 65 and older, and for those that have younger who have some underlying medical conditions. Uh-huh.
Would there be any harm in getting a full dose Moderna third shot?
Not known. It probably wouldn't. You might get a more sore arm and maybe a little bit more fever and headache. And some people certainly have, you know, who otherwise may not be immune compromised. But I'm sure Moderna has worked it out pretty carefully to balance the effectiveness and side effects. And if Moderna's clinical trials show that a half dose is sufficient to bump up the immune system, I imagine that's based on science. And we'll see what the FDA says. You know, don't want to jump the gun there. What about comfort zone with or lack of it? Everybody's going to take a wait and see.
Debbie, you're
Depending.
muted. Debbie, you're muted.
Yeah, I'm sorry. I'm waiting for the Moderna one, and I feel absolutely comfortable about it. And I'm really looking forward to the vaccine for the kids, which it does sound like by the end of, well, into November sometime it'll happen.
Mhm. Yeah, there was speculation that it might be the end of October, but I expect that's too optimistic. But we'll see. I think Dr. Fauci is talking end of November. He probably has his finger on the pulse. And Herb, excuse me, Arthur.
Oh, Marion and I both have had our Pfizer boosters. I had a fairly strong reaction to the second dose of Pfizer. I had very little reaction to the booster dose of Pfizer. And I was very eager to get the Pfizer booster. I mean, I had read that it increased your levels of antibody 3 to 5-fold at least. And now, you know, the information you provided is that it's going to be more durable and longer lasting. I'm very glad to have had that booster. I'm still being cautious about going into closed spaces where there are lots of people. And I do wear a mask when I go grocery shopping or I go into the drugstores or things like that. I'm not wearing a mask outside at all.
Yeah.
I have a question for Arthur. What was the reaction that you experienced?
With the second dose of Pfizer or with the booster?
With any of the shots?
The reaction I had with the second dose of Pfizer was about 24 to 36 hours later. I really was very fatigued. And it was primarily fatigue. I didn't have any fever or headache or anything. And I had a little soreness in my arm. With the booster, I had a tiny amount of pain in my arm and just a little bit of fatigue at about 24 hours for maybe 6 or 8 hours. And that was all.
Yeah, the big picture for side effects is that it's about 5% of people who have a strong reaction, where it's, headaches, fatigue, fever, muscle aches, or some combination of those. And occasionally that can linger, as we heard from, I think it was the director of the Cambridge Newton version of Newton at Home, who's had some symptoms which sound a bit like long COVID going on, for fatigue that lasted for a while. That's really rare. And so the reactions to the booster have been pretty much as Arthur described for most people. They also were for Sally Craig and I. A sore arm, if that's what you got with the first ones. And that's probably what one could expect for the Moderna and J&J, a similar reaction. If one had a terrible reaction to the second one, then the booster might be likewise. The other important thing, and I think related to Debbie's concern, is can we still be have the virus and transmit it to others? And that's the basis for CDC advising that we all continue to wear masks even after fully vaccinated, is because with this Delta variant, it seems we can get even asymptomatic infections and still have a lot of virus in our nasopharynx, which is presumably the source, or one of the sources for producing virus that can infect others. And since it's so contagious that having a lot of virus in our nasopharynx is worrisome enough that that Walensky made that broad recommendation, not Walensky, but the CDC, for that we all continue to wear masks. Now, so will the booster help us reduce transmission further? If it's so good at producing antibodies and so on, we might not get infected at all, even marginally in the first place, and therefore be less likely to be a threat to kids or others, or those who might be immune compromised. And there's no data on this that are usable, but the best sources, and this comes from the editor of the New England Journal of Medicine in a recent podcast, who said it's likely that we will be less likely to transmit. So it's likely there will be some protection in terms of being a risk to others with the booster. And that's, again, just based on the ability to ward off the infection in the first place by having good antibody levels, and those are the ones that have drifted down, that require the booster and might require another booster in a year or so. But in the meanwhile, I see a few others have joined us, and we've just been discussing the rationale from the director of vaccines at NIH, describing to us that the immune system really matures over this 6-month waiting period for the third dose. And rather than considering it simply a booster dose, we consider the Pfizer vaccine and soon probably Moderna and J&J as that extra dose at 6 months required or necessary to really complete the regimen and have durable protection. And there's pretty good rationale for that, and evidence from Israel, where they've given a lot of people a booster dose, and they have a good experience and really a great deal of protection. Well, one point that's worth making also is that it seems that both the 2 doses of Pfizer or Moderna, or a single from J&J, are better at protecting against severe disease than against getting the infection in the first place. And some of the reason for that is that the antibodies are only a part of the immune system, that there's the cellular response and the so-called B cells, or the memory cells, that are harboring or ready to go at building more antibodies when they are challenged again, if we get exposed to the Delta variant or any COVID-19 variant, but particularly the Delta that's so contagious, and that they leap into action, to ward off the virus, as before it really gains a lot of ground and causes us to be seriously ill. So that's why all these, and particularly the booster dose, are so effective at preventing serious illness. Some virologists have even suggested, well, it might not be a bad idea to get exposed to the wild strain and boost yourself up further going forward. Not that that's an advisable level, but there's that comfort level among virologists. Anne, you had your hand up.
Given the similarity of symptoms of flu and COVID, what about public policy? How important is it to differentiate, and what kinds of policy methods are going to be required to make that happen?
I think, as I understand your question, is if you start getting a fever and a sore throat, what do you do? Well, get a COVID test, certainly this fall still. And as I was going to get to a little bit later, make sure you get the flu shot, the quadrivalent one with the 4 different strains in it for seniors is and has a higher dose, the so-called senior dose for those of us 65 and older is more effective.
Sorry.
Sorry.
I was
Yeah.
just thinking more about research and trying to track all of this, whether it's just all going to go down the drain when people start getting either one.
Well, I expect the research is going to continue going on. The good news is we don't, for example, see another variant, a Delta plus or something like that. I mean, there's several other variants of interest according to WHO's criteria, but they're not taking over. It's still Delta is the winner, hands down, in terms of edging out all the other variants, at least in the US and mostly around the world. It's so contagious. Am I getting to your question? Okay, is anybody traveling or thinking about traveling? Judy? Judy Pollack? You're still muted.
Okay,
Can-
okay,
there-
you can hear me now.
Yes.
Right. I have well, let me just mention something, whatever. I didn't have a sore throat. I had a runny nose. I had a lot of phlegm. I was dragging, really dragging. And this lasted by about a week. I was not good. And I had been with someone outside eating who had been the previous night to a wedding in New York City. And the week later, I went to a urgent care and tested for COVID. I said, could you please give me the rapid test? Well, it turned out they tested me for 2 different things, one for the rapid and one the PCD, I believe.
PCR, presume.
PCR test. And they did a complete checkup on me because I had my chest was hurting and everything else. And they said it would take 1 to 3 days to get the second test back. The first one was negative. The second one came back 3 days later, and it was also negative. However, A couple of days later, I happened to have had a virtual visit with my physician. And I have asthma. And I felt, well, if it isn't COVID, it's asthma. So I'm telling her the whole thing. And she said to me, and she's at Brigham, she said, whether it was a virus or COVID, it brought on your asthma symptoms, but they are finding that mild cases of COVID are not getting a positive test. Now, have you heard that too?
I haven't particularly, but certainly there's no test that's 100% accurate. And there's a lot of ways, even the PCR test, which is kind of the gold standard,
Right.
can go awry. And 90% of perhaps true positives are picked up. And the way one takes the swab, whether it's doesn't really get to the right area or doesn't sit there long enough, and if I could
Okay.
just
Sorry.
finish, I mean, because you touch on a couple of really good points here. And the way it's handled afterwards, if it's been sitting out too long, if it's put into the diluent and that isn't refrigerated quickly enough, and then there's potential for laboratory error at the other end. So like every laboratory test, we think of these things, as precision science. There's a lot of human component in each of them in terms of, taking the test, transporting it, making sure it's handled right. And then there's just scientific inability to detect complete accuracy. But I like
where that night, who had been the night before to the wedding, found out subsequently, I'm not sure what day, that there were 10 COVID cases from this wedding. And she proceeded to test, I think she told me a total of 3 times, and her tests were negative. However, the same time that I got my symptoms, there were only 4 of us at this dinner outside, spread apart. Another person got hospitalized for symptoms. So, is it possible that this person who went to the wedding, even though she tested 3 times negative, could have been asymptomatic? Or how can this be explained? And I do believe I had COVID because a friend of mine called me. She did not have the same symptoms, but was also very tired. But she had something that I had at the end that was so unusual. We both had it.
Yeah. Okay. I want to move away from a little bit from personal diagnosis or lack thereof, which really
but
is.
I'm asking about people that you're.
Yeah. I'm going to try to address that right now.
Sorry, I'll be quiet.
No. It's just we want to broaden this out so it's useful to everybody. Certainly, the rapid tests have not performed really well in terms of picking up true infections. And it depends on, in part, how much virus we have on board in the way it's taken. They tend to pick up maybe a third or up to a half of true positives. If a rapid test does turn positive, they're almost always correct in that you really do have the virus. So it's more, rapid tests are almost used in schools, for example, as a public health tool. If you're picking up a third or even 50% of the people who are ill, you can isolate them quickly because it's a cheap test. It gives you quick results. and that's useful. But in terms of determining your own diagnosis, it's not so good. So that's why the PCR is the best. And as you and I had this discussion before, certainly if you're exposed to someone who is known COVID positive, isolating and letting other people know that they've been in contact in order to protect others and folks that they may be around, so we don't get inadvertently infected or infect someone else, is an excellent idea. We're still responsible for each other's care and health at several levels as we go forward. But with the rapid tests, and I want to mention one other thing, because there's been a lot of discussion about making rapid tests a lot more available. This head of immunology at NIH and vaccine development points out that we really don't have very well standardized rapid tests, and they're hoping to get better validated rapid tests. There's broad consensus that easy access to rapid tests is important for the public health as well as individual determination, but that there's so many out there, and they're highly variable in terms of their accuracy. And then also some recent studies have shown that those who use a nasal swab, this is rapid tests now, that go to the back of the nose, like the PCR test, the nasopharynx, are about 80% accurate at picking up true positives. Those that just have the anterior front part of the nose for the swab are less than 50%. And those that rely on saliva test, and some of these you can do at home, are almost useless in terms of accuracy. So they'll pick up some, but they miss a huge amount. So they really are to be avoided if you want something that's going to work pretty well. The other kinds of tests that are being used widely by some people is antibody tests. You can have your blood sent off, or some tests even that can be done at home, to measure the antibody level that you have. And I know of colleagues who have decided whether or not to go to Africa for an extended trip or not based on what their antibody levels were. Both the NIH and CDC do not recommend the antibody test, and in part, as Dr. Mascola said, because we don't know what it means. And the interpretation of what level of antibodies is protective is unknown, and there's no good way to determine that. And the fear is that there's a lot of people being misled by saying, oh, okay, I see the antibody levels are this, I guess I'm good. And I'll go ahead and go to that wedding indoors or not. And that may not be the wisest decision based on a fairly indeterminate test. So measuring one's own antibody levels right now is not recommended by CDC or folks at NIH who understand where we're at with the science on these. So maybe I'll stop there for a moment and open it up for any other questions or points. Welcome, Cynthia. I see you've joined us. Thanks.
Arthur, go ahead.
I just wanted to say that the prevailing knowledge is that it takes about 3 days for someone who's been exposed to then be able to transmit. So if you've been with somebody who is in a dangerous situation just the day before, it's unlikely that they could transmit the disease. It takes some time for them to inhale the virus and for the virus to begin to multiply within their own body before they can spread it to someone else. The other thing is, as Douglas said, the PCR test is extremely sensitive. So even people with mild COVID, the amount of virus that they're producing, which might be small, is going to be picked up by the PCR. But the mechanics of doing the test might mean that you get a false test. But it doesn't take much virus to give you a positive PCR.
Mhm. Yeah, thanks for that,
I'm still
Arthur.
learning how to.
The other point that may be coming up is on vaccines, the mix and match. That is, you know, if you started out with Moderna, would you want to have a Pfizer, or maybe if you had Pfizer, Moderna, or J&J? And there's this was addressed a little bit by this fellow from the NIH, and there's a lot of interest in that. There's theoretical reason to think that one might get a better hybrid response if you have multiple different vaccines. That's a theoretical possibility. And there's studies that NIH is undertaking that should be showing results fairly soon. So I expect this will be another item to be looked at. This guy was particularly excited himself, you know, to find out, you know, whether it makes any difference, positive, negative, or other. So something also to be anticipating. So lots of things coming up about Moderna, J&J, children's vaccines, and mix and match. But coming back to the Pfizer and the booster dose. So we know in CDC, the advisory committee has distinguished between should and may receive the booster dose. And these are guidelines, not prescriptions. So those who should, those over 65, anyone 18 and older who's in a long-term care setting, people then who are 50 to 64 with an underlying medical condition. So even though you're otherwise not immunocompromised, but have heart disease or lung disease, diabetes, obesity, and a variety of other things. And then there's a whole group of those who may be given it based on things like the following. 18 to 49 years old with any underlying medical condition, 18 to 64-year-old who are at risk of getting COVID based on their occupation or their institutional settings or their exposure, such as frontline health workers or frontline workers, for example, in a grocery store. Or other public-facing people. So this woman who was on the committee that debated all these things said, "Well, then who's left?" And it's just about everybody who's seen a doctor for any reason in recent times could qualify, and she was fairly comfortable with that. And this is also the reason, I think, why Rochelle Walensky, broadened it out, overruled the advisory committee that had a close vote about whether healthcare workers should also be included. And she said yes. So the other evidence is that with the waning immunity, why not people right now 18 to 64, as Israel has found out, they just opened it up to everyone in the country. I expect that is where we'll be going soon. And it seems also that no one's requiring one to say, you know, are you a healthcare worker, or do you have lots of extra additional exposure? You're a candidate. That falls in the may also receive. And that guidance, she said, would help people decide, you know, do I need to talk to my doctor? Well, not necessarily. Take a look at the CDC broad guidance, you know, of all the medical conditions that they list, which is as long as your arm. in terms of things which might qualify. Debbie?
Douglas, this is sort of a moot question, but with respect to the committee's original decision not to offer it to healthcare workers, but to offer it to people over 65, many of whom are not out and about seeing people. What was the original rationale not to include healthcare workers? Do you know?
It was a highly debated discussion, apparently, with the Advisory Committee on Immunization Practices. And this is the CDC committee that decides on implementation, who should get it and when and how, once FDA has approved it. I think the thinking was, that they're otherwise healthy and not at risk of serious disease. But the consideration to approve it by Walensky was, the potential for also transmission to others, that you're at a high exposure area, an asymptomatic infection and being able to transmit. So it's in part for epidemic control, as well as protection for them. And I think the fairly good evidence that the antibody response, and as we learned from the outbreak in Provincetown, 3/4 or 80% of people who do get a quote breakthrough infection do have symptoms, so it's workforce protection and so on. So there was disagreement, as to whether it's really necessary for that group or advisable in this case. It's an advisory, not a
Yeah, it just seems like a no-brainer that you take the people who have the most exposure to sick people.
Yeah. Yes. Yes. Arthur?
Yeah, I couldn't agree with you more. It makes no sense at all, particularly when you realize most of the people in the hospitals are wearing surgical masks, which don't prevent, they're really not the best kind of mask to prevent transmission to others. And if I'm sick in a hospital, I want to know that my risks of getting COVID are as minimal as possible. So I don't understand it.
Yeah. Yeah, and we've not discussed long COVID for a while, but the jury still seems to be out for those people, for example, at Provincetown with a breakthrough infection and got some headache or muscle aches for a few days, whether they might also have some symptoms long-term, from that, and a bit of brain fog to go with it, or yes or no, that long COVID is still pretty common even for those people who have a mild case. So that would be something I would consider also as part of it. But Ed?
A friend of mine was fully vaccinated and had a breakthrough infection, and she's wondering about the need for a booster if you have natural immunity.
I think the guidance would be to go ahead and get it. Probably no reason not to. I mean, I'm speculating now. I haven't seen anything directly on this, but certainly, given the past, those who have had a natural infection and then got their first or even second dose, got a big bump up for their immunity compared with those who just got the first dose of the vaccine. So the natural infection is like another booster in the way it operates for the immune system, which is what we would expect, and that's been documented in terms of things like antibodies and so on that we can measure. Mm-hmm.
Thanks.
So how about flu vaccines? Is everybody on board? This is a good time to get one's flu vaccine. The quadrivalent certainly seem to be available at Newton Wellesley, where Sally Craig and I got ours. Has anyone else had any trouble getting the high dose?
CVS and Newton Center had it.
Good. Yeah, some years they're a little bit shy, or some places have it and some don't. the sore arm effect can be a little bit stronger with the high dose, but it didn't seem to make much difference for us. There's other news that's out there for an antiviral drug that's been hitting the newspapers, and the administration is making some enthusiastic noises about that. Another tool in our toolbox to treat COVID-19. Other antivirals have been around for some time, certainly for HIV/AIDS, a whole host of antivirals, which are really the stable for treating HIV. And there's one that's available for influenza, which should be taken early on within the first 48, 72 hours. Tamiflu is the trade name for it. It's kind of lost some of its effectiveness, and again, needs to be taken early in the course. So before you really know what you have, much less have whether it's documented to be true influenza or just a bad cold with any of the other myriad other viruses, makes it kind of tricky to really make use of that antiviral. And there's concern that the same might be true with this COVID antiviral, which even in the early studies that have been produced, and we're still in the early phases of getting data on this, shows it to be about 50% effective in terms of helping people with moderate to mild illness modulate their disease. The monoclonal antibodies that are given by, but it is a pill, so it would be easier to take the antiviral if it comes to market. Monoclonal antibodies require an intravenous infusion over a few hours, but they're more effective at about 70% for people at risk of severe illness in terms of treatment. So the treatment side still, isn't terribly exciting, in terms of protection. There's some things that are coming along, and there's fewer people dying, certainly, of those who do get full-blown COVID, but preventing it is still the watchword. When it comes to folks who are vaccine hesitant, one of the troubling features of the booster doses is apparently surveys have shown that about 1/3 to 2/3 of people who are vaccine hesitant are more confirmed in their hesitancy by the appearance of a booster dose on the scene, saying, well, that just goes to show it really isn't effective, that they have to keep boosting it. So that's been a bit of a discouragement to public health types at CDC and so on. So that's the world we live in, yes. But the good news is that in fact, it's the completion of the series. I'm not sure that message, aside from the 2,000 internists who are listening to Dr. Muscola, are getting that message that we should think of it as completion of the series, and it's needed and appropriate, and probably in the longer term, probably the most important one that we get. Tamara.
Has a question.
Sorry, I had to leave for a few minutes. I don't know if this question was asked. Now that Symphony Hall is opening up and other concerts, I was at one Sunday, and you had to show your card that you'd been vaccinated, and you had to wear a mask. And I felt, but there's no separation on the seating. I felt pretty comfortable, but in inviting some other people to go with me to another event somewhere else, I've been surprised at the number who say no, not yet. And I'm wondering, am I being foolish? But it's one of my most fun things to do, and I'm really reluctant to give it up.
Yeah, well, those are surely personal decisions. I trust you've had your booster dose or Pfizer?
Not yet, because I'm Moderna, and as far as I know,
right.
That's not available. John has had his, he was eligible early for his his booster. I
Right.
certainly plan to and plan to get my flu shot.
Yes, yeah. As we were saying earlier, the discussion, the Moderna application for booster doses for everybody over 65, presumably, is going to be considered by the FDA in a few days.
No, I heard
And-
that.
And presumably they'll approve that. So that would be appropriate to get that then. Yeah, and until one has the booster dose, Moderna seems to have provided more durable protection with the 2 doses than Pfizer. It doesn't wane as quickly, it seems. Yeah, I think, we haven't talked about the need to still continue, wearing masks, social distancing when we're indoors with other people, and especially those who may not be vaccinated, particularly kids. It's very, very appropriate, and certainly, those of us applaud the public health message and personal protection message to show your vaccine card when you're going to be inside a building and close to other people.
Yeah,
Spacing would be better, but I know that's hard.
I guess then what they're trying to do, first of all, they've, at least in Symphony Hall, have supposedly improved the air filtering system.
That would be
But
good.
everyone was wearing a mask. That was
Uh-huh.
required, and everyone had been vaccinated. So that's
Yeah.
what made me feel
Yes,
pretty comfortable, but I guess it's still a risk.
yeah. But the good news is that severe disease is very, very unlikely. Barbara,
Yes, hi. Could you, I don't know if I missed it or not today. Excuse me. The timing between the flu shot and the vaccination, can it be close or can you do it the same day?
I understand it can be the same day, but I defer if somebody else has seen that guidance definitively.
Well, Scott did it the same day.
Yes, I think it can be done the same day. Yeah.
I do know that, I know that Kathy in our office had hers done the same day.
Okay, well,
I had my booster, Pfizer booster, and my flu shot, same day, different arms.
okay, well, there's the answer in practice. And I think, while the previous guidance was, no other immunizations for 2 weeks before you get your Pfizer or Moderna, the flu vaccine is an inactivated virus. So the theoretical possibility that they're competing with each other may not be there. So good. Yeah, get both. Okay, I think we're, any other burning questions or thoughts or comments?
This is not a medical question, but do you have any successful messages you can give to people who are vaccine hesitant or stubborn or whatever they might be?
Yeah.
I mean, statistics are for if you get sick, you're going to get a lot sicker if you're not vaccinated. It doesn't, obviously it's not reaching people.
Yeah. What I understand from people who work on this is to, ask questions, what is the basis, and very often, a trusted source. Doctors still seem to be one of the best sources for helping people answer their questions and their hesitancy. But other leaders do, or sometimes you can point them in the right direction for their particular risk. It was developed too rapidly. We don't know what the long-term side effects will be. Well, it wasn't very rapid. It was based on science that's been in the works for a dozen years and built on that. And the clinical trials have been very robust, and there's 4 different sets of complication reporting systems, including for extremely rare events that are in place. So I mean, there's a lot of rigorous looking at long-term side effects. I'm not sure there's any one right way, but sometimes helping people get access to questions, to information that addresses their particular concerns is useful. Arthur, and then Alan.
I'm reading a book by a climate scientist who happens to be a deeply religious person. And she talks about the problem of getting people who don't believe in climate change to accept that it's happening. And as soon as you mention the word climate change, these people close their minds, and no amount of fact is going to help them. In fact, the more facts you give them, the more resistant they become. And I think the same thing is true of these people who are reluctant to get vaccines. So I think the thing to do is probably to discuss it by not talking about vaccines and say something maybe like an ounce of prevention is worth a pound of cure. Say nothing about vaccine, but just change the topic in a way that they understand, something else. So I would say, again, just remind them that a pound, that an ounce of prevention is worth a pound of cure.
And there's a fair number of people who are on a spectrum. It's not never, it's I think I better wait and see what happens, or versions of that. Alan, do you have the answer to Debbie's question?
I do not, but I have another question. Is there any discussion on COVID boosters annually, as we have the regular traditional flu shot?
Yes, that again, based on the director of vaccine research at NIH's comment, he expects there will be probably a need for boosters, perhaps on an annual basis. We've got another 12 months to see whether there's waning immunity that's of concern for those of us who've had the booster, or maybe even in 6 months. I hope not, but yeah, it's anticipated that we will probably need boosters, and it's anticipated that COVID will be with us for the longer term. And hopefully it doesn't get too smart with another super variant that's escaped the immune responses that we have now. Judy, did you have a question?
I did. I am going to be flying in a couple of days, and I am going to mask up. I've had the booster and all, but this flight is a very long flight. And so I will be attempting to eat something, but I really don't want to take off my mask. I know a salad to put your fork in your mouth. Any suggestions?
Well, I think those of us who've flown and also like to eat, sort of everything is about risk reduction. So the shorter period of time that you have your mask off, the better. And also, as we've discussed on previous times, the airflow in aircraft are really quite good in terms of the protection factor. Also, as I make a habit of taking the overhead vent, my personal air vent, blowing it on my face. The air that's circulating through the aircraft is 50% outside air and 50% that's passed through a HEPA filter. So all the air coming through that vent is free of the aerosols that might be produced by your fellow passengers somewhere along the line, to put it scientifically. So keeping that airflow, on your face so that you're breathing that in is another protective factor. And the airlines have a real vested interest in keeping us as safe as possible. And so probably inside the aircraft is a better place. The legal seafood at Logan might be another matter, or going through the TSA line, or crowded areas there.
Thank you.
So how are we doing? Well, we've not exhausted everything, but thank you for your questions and your participation. This has been a lively discussion, and I hope it's been useful. Any parting thoughts,
Thank you, Alan. Alan, Douglas. I'm just looking at Alan when I'm saying, thank you, Alan, for being Alan. Thank you, Douglas,
Yes,
for the presentation.
So it must
Yeah.
be when Douglas mentioned brain fog.
Yes, that's right.
Oh.
Yes, yes.
Okay.
I'm having brain fog. I just
Okay,
want you to know, just so that a few people came on late. I did record the whole thing, so if you want to get a hold of the first, 20, you'll get the whole link. But if you do want to get a hold of it, shoot me an email. It'll be ready in a day or two, and I can send the link off to you.
Yeah, and the really good news was at the beginning, so.
Yeah, yeah.
People are smiling, they're not shaking their head. Okay, take care, everyone. Stay
Thanks,
well.
Douglas.
Thanks.
Okay, bye-bye.
Bye.